Hepatitis B infection from a global perspective has had an enormous impact on morbidity and mortality. And in this presentation, I'm just going to tell you a little bit about some of the key landmarks associated with its history, its transmissibility, the burden of infection from an international and a UK perspective, a little bit about who should be tested and the tests that characterise the infection, something about the clinical outcomes and disease progression, and then treatments to try and prevent disease progressing, and then methods which are designed to prevent infection occurring in the first place. Now, hepatitis B has probably been causing disease for many hundreds of years, but it's only in 1967 that Baruch Blumberg identified a component of the virus, the Australia antigen, and following the characterization of the infection and the development of tests to identify the infection in the 1970s, the first vaccines were licensed in 1982. That was 15 years between discovery and vaccine availability, and this compares with HIV, where you have discovery in 1983 and there's certainly no vaccine on the horizon with that. Then declarations by the World Health Organization in 1992 and again in 2004 to promote universal vaccination. And the idea is to eradicate hepatitis B infection in the same way smallpox was eradicated and polio has nearly been eradicated. And then the licensing of drugs to prevent disease progression, the less effective interferon in 1991, and the more effective nucleoside analogues in recent years. Now, there are three principal ways in which hepatitis B is transmitted: through unprotected sexual intercourse, through blood-to-blood contact, for example, sterile, invasive healthcare procedures and injecting drug use, and then from mother to child, particularly at the time of birth. Hepatitis B is a very infectious agent, it's more infectious than HIV and hepatitis C. And for example, if a healthcare worker sustains a sharp injury from a source that's hepatitis B infected and highly infectious, that individual has a 30% chance of becoming infected. Compare that with HIV. If the source patient is HIV positive, the chances of infection occurring are 0.3%. Hepatitis B is a sturdy virus and can survive outside the body for at least 7 days. And that's why it's very, very important that blood spills are managed effectively with disinfectants. If we want to just look at the burden of infection, about 1/3 of the world's population has evidence of ever having been infected, and of that 1/3, 350 million are currently carrying the virus, and this compares with 35 million individuals with HIV, so a tenfold difference there. And then 500,000 to 700,000 people each year dying from hepatitis B, so quite clearly hepatitis B in global terms is a very, very important condition. The World Health Organization categorizes countries into high, intermediate and low prevalence ones. The high ones, with prevalence of 8% and over, these tend to be in sub-Saharan Africa and Southeast Asia. The intermediate ones have a prevalence of between 2 and 7%, and these are in North Africa, parts of Eastern Europe and other parts of Asia, and then the low prevalence ones mainly in the rest of the world, including Northern Europe. Now, if we move on to the United Kingdom, it's a bit unfortunate that the UK estimates are limited because of restricted data and also because the estimates are not particularly up to date. But nevertheless, the UK has got a sizable hepatitis B infection problem. In England, the prevalence is probably around about the 1 in 250 mark. In Scotland, 1 in 500. The English estimate is probably a bit of an underestimate because in the last decade, quite a large number of individuals have come into the country from high prevalence countries, and that has to be factored in. And the 2011 census data will help to provide more robust estimates of the size of the infected population. I think there's no question, though, that more people in the United Kingdom are infected with hepatitis B than ever before, and this means that the general population, which is by and large not immune to hepatitis B, is more at risk of coming into particularly sexual contact with hepatitis B than ever before. So that is something that's to be borne in mind. Now, if we move on to acute hepatitis B infection, and by that I mean people presenting with symptomatic hepatitis B for which there's evidence that the infection was recent, the numbers peaked in 1985 at a time when needle and syringe sharing was rife, and since then they've fallen and plateaued around about the 600 to 700 mark. But I think you have to take into consideration that not everyone who gets hepatitis B is symptomatic, not everyone who's symptomatic actually goes on to get a test, and not everyone who gets a test gets reported. So the real numbers are more likely to be 2,400 to 2,800. As far as the 2009 cohort is concerned, its characteristics tells us that infection among the traditional high-risk groups of men who have sex with men and injecting drug users relatively uncommon, and this is probably due to the effectiveness of vaccination achieving relatively high rates of uptake among these risk groups. Now, it's important to understand a little bit about the structure of the virus because this tells you or gives you an understanding of the tests that characterize infection. So we have an outer envelope, the hepatitis B, the surface antigen, an inner core, the core antigen, a partially double-stranded DNA molecule in the middle, and then also the E antigen, which is the third antigen associated with this virus. The tests are very complex, but what's important to know is that we have tests which can distinguish between current infection on the one hand, past infection on the other hand, and no infection. And then we have tests that can distinguish between high infectivity and low infectivity, tests that can distinguish between recent infection and long-standing infection, and tests which can distinguish immunity, so an individual who's got immunity as a consequence of vaccination as opposed to immunity due to past infection. Who should be tested? It is quite remarkable. We've had tests on the go for 40 years, and yet there's no formal UK or European guidance in hepatitis B testing. And this is being rectified by the National Institute for Clinical Excellence, so guidance will be out soon, and it's likely that we'll follow similar lines to those for the United States, where, as well as the traditional high-risk groups being offered and recommended hepatitis B, also individuals from high and intermediate prevalence countries will also be offered hepatitis B testing. It should also be noted that pregnant women in the United Kingdom have been offered a hepatitis B test since 2002. Very important, of course, in terms of detecting babies born to infected women and then vaccinating them to prevent onward transmission. The main clinical outcomes associated with hepatitis B are acute asymptomatic infection, which is generally associated with infants, acute fulminant hepatitis, a rare, usually fatal condition involving the destruction of the liver, acute symptomatic hepatitis characterized by jaundice and abdominal pain and affecting up to 50% of adults, and then chronic infection and the diseases associated with long-standing chronic infection, such as cirrhosis, liver failure, and hepatocellular carcinoma. The interval between someone acquiring the infection and developing symptoms is on average 2 to 3 months, and if that individual is still infected 6 months later, he or she will invariably go on to develop chronic infection. Adults are generally good at getting rid of their infection, and that's because they have mature immune systems. Infants and young children generally, when they're infected, go on to develop chronic infection because their immune systems are relatively weak. Proportion of individuals who've got chronic infection go on to develop phases of immune activity which are associated with inflammation. And if that inflammation is prolonged and pronounced, fibrosis of the liver develops, and cirrhosis and liver failure are merely advanced stages of that fibrotic process. The factors associated with disease progression are excessive alcohol intake, older age, among others. There are treatments to prevent hepatitis B disease progression, and they can be divided into two categories: the immune modulators such as interferon and the antivirals. The immune modulators essentially stimulate the individual's immune system to reduce replication of virus and to eradicate virus, whereas the antivirals directly attack the virus itself to prevent viral replication. And the recent antivirals, nucleoside analogues of tenofovir and entecavir, are effective, but there are downsides, and these downsides include the cost, the fact that they can cause significant adverse reactions. They don't cure hepatitis B, they merely suppress it, and therefore they have to be taken long term. And there's always the possibility of drug resistance. So the old adage that prevention is better than cure is highly applicable to hepatitis B, particularly since in fact the treatments available in most instances don't cure the individual. Two approaches to prevention: interruption of routes of transmission, for example, blood donor testing, needle and syringe exchange for injecting drug users, and the use of condoms. And these approaches have made a serious contribution to the prevention of hepatitis B in the United Kingdom and elsewhere. But the most effective way of preventing hepatitis B is through active vaccination. There is passive immunisation through the use of immunoglobulin, and that can give a rapid response, but it's short-lived and is generally only used in the post-exposure prophylaxis situation. Vaccination, active vaccination, two approaches: targeted, which is the UK approach, the Green Book approach, and then universal vaccination. And around 177 countries worldwide, that's about 82% of countries, as at 2008, had introduced hepatitis B vaccination into the infant immunisation schedule. Numerous studies have demonstrated how effective this vaccine is in reducing the prevalence of hepatitis B and the incidence of acute infection. And these studies have occurred in many countries, including Taiwan, Gambia, Italy, Alaska. And in the UK, we used to see outbreaks of hepatitis B among injecting drug users. These are rare now, and that's because we are achieving high uptake rates of hepatitis B vaccine among injecting drug users, particularly through the prison immunisation programmes. Yes, after vaccination, antibodies do decline, but the immune response to vaccination is generally an effective one, and booster doses are not usually necessary. And the safety record of the vaccine is exemplary. So In conclusion, the prevalence of hepatitis B infection in the United Kingdom is increasing, and it's likely that there are more people now infected with hepatitis B in the UK than ever before, and that means that people in the general population who are generally not immune to hepatitis B are more likely to come in contact with hepatitis B. It's a serious, life-threatening infection, and although treatments are available to suppress the virus, there are downsides to these, including the cost and the fact that these treatments don't cure in most instances, and that means they have to be taken long term. And so, without any question of doubt, the mainstay of both hepatitis B infection prevention and hepatitis B related disease prevention is vaccination.